Welcome to the Explainer. Today we're taking what is honestly a super dense, highly technical, and let's face it, overwhelming subject, the rules of medical coding, and turning it into a really practical, actionable blueprint for your practice. I mean, if you've ever stared at a patient chart and just felt this wave of anxiety wash over you about whether to bill a level 3 or level 4, well, you are definitely in the right place. We're going to start with a pretty harsh truth right out of the gate. E&M coding, it isn't just administrative paperwork that you can hand off and forget about. It is literally the financial and legal lifeblood of healthcare. Errors here don't just cause minor annoyances. We're talking about denied claims, massive recoupments, and in the absolute worst cases, severe civil or even criminal penalties. But hey, don't worry, we're going to build your confidence today so you can avoid these pitfalls entirely. All right, here's our roadmap for today. First, the stakes of EM coding. Second, core code structures defined. Third, mastering medical decision-making. Fourth, navigating split/shared visits. Fifth, modifiers and telehealth roles. And finally, number 6, fraud, waste, and abuse. So let's jump right into section 1, the stakes of E&M coding. There are really 4 main pillars driving why we do this. Yeah, reimbursement is the most obvious one, right? It dictates how providers get paid for their time and decision-making. But honestly, it goes so much deeper than that. Correct application of these codes ensures your documentation is standardized across every single specialty. It guarantees compliance by proving medical necessity. And finally, these codes are heavily used in value-based care models to actually measure provider performance and patient outcomes. It's this entire ecosystem, and it all relies completely on your accuracy. Moving right along to section 2, core code structures defined. At its core, you gotta ask, what exactly is an EM code? Well, these are Category 1 CPT codes published by the AMA, and they run from 99202 to 99499. But the absolutely most important word to remember here is cognitive. These codes act as the standard language we use to describe the intense cognitive work, the critical thinking, and the medical decision-making that goes into patient visits. We're not talking about physical procedures or surgeries here. We are strictly quantifying brain power and time. Now, let's talk about the strict 3-year rule. This acts as a really rigid decision tree. You can't just guess if a patient is new. A new patient is strictly defined as someone who hasn't received any professional services from the exact same specialty and subspecialty within the exact same group practice in the last 3 years. So think about it like this. If Dr. Smith and Dr. Jones are both cardiologists in the exact same group, and Dr. Jones saw the patient 2 years ago, well, that patient is established for Dr. Smith today. You'd be surprised how often this rule trips up practices. All right, into the really good stuff, Section 3, Mastering Medical Decision-Making. If you take absolutely nothing else away from today, please memorize these 3 pillars. Number and complexity of problems addressed, amount and complexity of data reviewed, and the risk of complications or morbidity. I always like to think of MDM as a 3-legged stool. To correctly pick a level of service based on MDM, you have to meet or exceed the threshold for at least 2 of these 3 elements. You don't need all 3, but you absolutely positively must have 2 firmly documented to justify your code. The AMA explicitly spells out the exact requirements for straightforward and low complexity. Just think about how a self-limited or minor problem, or maybe a single stable chronic illness, puts you firmly in that low category. The data review here might be super minimal, maybe just looking at a couple of unique tests, and the risk of morbidity from diagnostic testing or treatment is, as you'd expect, correspondingly low. It's a highly structured system. Now watch how this scales up into moderate and high complexity. This is where the stakes get significantly higher. Notice how something like prescription drug management instantly bumps the risk profile up to moderate? And if you're making decisions about emergency major surgery or dealing with an acute illness that poses a real threat to life or bodily function, you are operating way up in that high complexity tier. Your documentation has to paint this picture crystal clear to support a level 4 or 5 visit. Okay, Section 4, Navigating Split/Shared Visits. So a split or shared visit happens when a physician and another qualified healthcare professional, like say an NP or a PA, work together as a cohesive team to provide care for a patient during a single encounter. They're both actively involved, sure, but the million-dollar question is always, whose NPI does the service actually get billed under? The crucial point to remember here is that whoever performs this substantive portion of the visit is the one who gets to bill for it. Based on the guidelines, this means performing either more than half of the total time spent or performing the substantive part of the medical decision-making. So, if the physician is the one who ultimately synthesizes all that data and crafts the management plan, essentially taking responsibility for the MDM, they can bill for the service, even if the NP gathered a big chunk of the initial history. But you've got to be cautious because this is a massive area for billing errors. Next up, Section 5, Modifiers and Telehealth Rules. We really need to sharply contrast two of the most heavily audited modifiers out there, 25 and 57. Modifier 25 is used for a significant, separately identifiable EM service that happens on the exact same day as a minor procedure. Think of a patient coming in for a routine hypertension follow-up, and while they're there, you also happen to remove a wart. Modifier 57, on the other hand, is strictly for an EM visit that results in the initial decision to perform major surgery, like evaluating severe abdominal pain that leads straight to an emergency appendectomy. Remember, they are absolutely not interchangeable. When you look at real-world clinical scenarios, you can clearly see why precision here matters so much. A major reason for clean denials is slapping on Modifier 25 without documenting a truly separately identifiable service. So if an orthopedist evaluates a worsening shoulder and decides to inject it right then and there, the note has to clearly separate the evaluation of that worsening condition from the standard prep for the injection itself. Without that distinct documentation, bam, the claim gets denied. And that brings us to our final part, Section 6, Fraud, Waste, and Abuse. Protecting yourself really starts with having a bulletproof workflow. First, you've got to rigorously review the clinical documentation. Second, select the absolute most specific ICD-10 diagnosis code. Try your best to avoid those unspecified codes whenever you can. Third, link that exact diagnosis directly to the corresponding EM CPT code. And fourth, always validate against specific payer policies, like local coverage determinations. Sticking to this strict four-step workflow guarantees that medical necessity is properly justified and perfectly mapped. Now, you really have to ask yourself, are you billing for visits that never happened? Or are you maybe just misusing modifiers to bypass edits? It's critical to ask this so you understand the legal boundaries of your billing practices. Look, a lot of providers think compliance issues are just cartoonish villainy, like billing for ghost patients in some dark back room. But the reality? The vast majority of compliance penalties come from systemic, repetitive administrative errors that simply look like intentional manipulation to an auditor. When we break down the differences, you'll see a high-contrast comparison that you absolutely need to understand. Fraud is intentional deception. That's upcoding a visit you know for a fact was simple or billing for a service you never rendered. Waste is essentially just bad resource management, like ordering tests you don't really need. But take a close look at abuse. Abuse includes practices that are inconsistent with sound medical or fiscal rules, like just repeatedly slapping a modifier 25 on claims purely to bypass an automated edit. The scary thing is, you don't actually have to be malicious to be guilty of abuse. You just have to be negligent. So what actually gets you audited in the real world? Well, these are your top audit triggers right here. Repeatedly billing level 4 and 5 codes for almost every single patient, that's going to immediately light up your practice and payer analytics dashboards. Other massive red flags include cloned notes, where you're just copying and pasting EHR text from patient to patient, missing all the details that actually justify your MDM, and submitting claims for notes that the provider never even signed. Always remember this golden rule. Just because a code exists, and just because you technically clicked the right little boxes in your EHR, does not mean it should be billed. Medical necessity is the overarching criterion for payment. Everything you do has to be completely backed by clinical justification. I mean, if a patient comes in for a simple paper cut, you definitely shouldn't be performing or billing for a comprehensive multi-system review. The severity of the problem must drive the complexity of the visit. So I'm going to leave you with a bit of a provocative thought today. Is your documentation truly audit-proof, or are you unknowingly leaving your practice exposed to crippling financial risk? Take a really hard look at your charts tomorrow and ask yourself if an auditor would see the exact same complex cognitive work that you experienced while you were in the room. Thank you so much for joining me to unpack these critical concepts. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.